Just to let everybody know, the meeting is being recorded, so if you're not comfortable, feel free to turn off your video. The recording will be available on the website of SiOG and on the member portal. So just so that you're aware. Welcome everyone to our second webinar of 2025. This is our Q2 webinar. We have Camille Chakiba, who's a medical oncologist in Bordeaux, and she'll be speaking today about expectations and priorities of older adults with cancer, the priority multi-center cohort study. I will turn it over to Camille.
Thank you very much, Kristen, for the presentation. So I'm really happy to present to you the results of this study that I already presented at the last SIOG in Montreal. So I'll start, sorry, check. So these are my conflict of interest. So the background of this study was to establish treatment goals for older patients. And there is an old study that you probably all know about treatment preference of seriously ill patients published in New England in 2002, asking 206 patients over 60 with cancer, heart failure, and respiratory insufficiency about their expectation with treatment. To summarize, patients would accept treatment for all these conditions, even if the burden of the treatment was high, if they were assured that they would go back to their current health status, and they wouldn't accept treatment even if the burden was low, if a severe functional impairment or cognitive impairment was expected. So patients want to maintain ability in the physical and cognitive aspects, and the balance survival, quality of life is probably different from younger patients. Angeline just arrived and they performed a very extensive study on patient-reported outcome in geriatric oncology, and that can be a very helpful tool to use to assess patient expectation. So the primary objective of our study was to describe the priorities of older patients with cancer receiving their first medical treatment at the start and after 3 months of treatment. We also described the expectation, the evolution of priorities over 3, 6, and 12 months, and compared priorities across 3 groups: patient 70 and over, age 18 to 69, and physician. And we also collected data from the geriatric assessment, and one of the goals is also to assess association between patient characteristic and priorities, and also overall survival, but we don't have these 2 results now. So it was a 2-part study. First, a prospective, observational, unicentric study conducted in Institut Bergonié in Bordeaux in 2016 that included 80 patients. And the second part was a multicentric national study with 9 centers, different types of centers, comprehensive cancer center, private center, and also a public hospital. And 320 patients aged 70 and over were expected, and 100 younger patients aged 18 to 69, which was the comparison cohort. And this part took place from January 2018 to January 2022. And the primary endpoint was priorities ranked among the top 4 out of a list of 8 priorities at inclusion and after 3 months. So you'll see a bit later on the list of priorities that we defined. So inclusion criteria were men or women aged 70 and older for the older patient cohort, and below 70 for the younger patient cohort, with a performance status from 0 to 3, first-line medical treatment, either chemotherapy, targeted therapy, hormonal therapy, or combination, in neoadjuvant or adjuvant or advanced or metastatic setting, and patients with different type of solid tumors and lymphoma were included in the trial. Life expectancy had to be of more than 3 months. Patient with only surgery or supportive care couldn't be included. So we defined 2 questionnaires, and patients had to pass self-administered questionnaires to define if this expectation were for them not important, a little, moderately, very much, or very important. And among these 8 expectations, treatment efficacy, life expectancy, autonomy, daily tasks, social activities, burden of treatment, toxicity, and economic burden were assessed. And then they had to list the 4 main expectations according to their priorities in relation to cancer treatment. And physicians also had to list their 4 main priorities for this cancer treatment. So just to define 2 of the expectations, which are a bit touchy, treatment efficacy was defined as an improvement of symptoms and or regression of disease by cancer treatment. And autonomy was defined as the possibility of staying at home and avoiding having to change places of residence, and possibility of avoiding one of more hospitalization related to cancer that is currently being treated. The geriatric assessment included CLG, socioeconomic questionnaire, ADL, IADL, MNA, MNS, GDS, and time get up and go. And patient also had quality of life assessment. They had consultation at 3, 6, and 12 months with a questionnaire and oncogeriatric follow-up, and also follow-up data on tumor assessment, unplanned hospitalization record, and evolution of social assistance. So, in the older patient cohort, 211 patients were accessible for priorities. And in the younger patients cohort, 97 patients were accessible on priorities. So the median age of the older cohort was 79 years, and the median age of the younger cohort was 61 years, reflecting the age of a patient with cancer in general. 2/3 of patients in both cohorts were female. More than 80% were PS0 or 1. Half of the patients were in early stage and half in metastatic stage, and breast and lung cancer were the most represented types of tumor. So, to present the results of patient expectation, treatment efficacy was reported by the patient as either very or quite important for 93% of patients. Autonomy was reported as very or quite important for 96% of patients, and life expectancy for 84% of patients. These are the results of the older patient cohort. The top one priority was treatment efficacy for both cohorts, with this priority cited by 73% of older patients and 79% of younger patients. Autonomy was cited by 13% of older patients at their top one priority, and life expectancy was cited by 14% of younger patients. And here are the results of the primary endpoint, which is top 4 priorities. So treatment efficacy was the most cited expectation in both older patients, which was 94% of the patients, and younger patients cohort. And then autonomy was the second most cited expectation for older patients in 86% of cases, and life expectancy for younger patients in 82% of cases. We also performed an exploratory study with 2 cohorts, patients over 80 and patients 70 to 80. And what we can see is that treatment efficacy is still the most cited expectation by 93% of patients over 80 years old, which is similar to patients below 80 and for the younger cohort. And autonomy is even more important in patients over 80 because it was cited by 91% of patients, and life expectancy is less important because it was cited by 61% of patients over 80. We also assessed the stability over time, and what we can see, these are the results for the older patient cohort, is that treatment priorities didn't change between treatment initiation and 3 months after treatment initiation. The only a priority that decreased was toxicity. And then we also assessed the rate of agreement between pairs, older patient and physician. So that was 1 patient paired with his physician, and we tried to determine if patient and physician agreed, which means either prioritized or did not prioritize one of the expectations. And for treatment efficacy, it was prioritized for 94% of patients and 92% of physicians, and the agreement rate was 87%, which means that 87% of the 200 patient physician pair agreed, either prioritized or did not prioritize. And for life expectancy and autonomy, the agreement rate was much lower, which was around 60%, which means that physician did not predict treatment patient expectation. And the last interesting concept is that toxicity was very different from physician to older patient, because 32% of older patient prioritized toxicity versus 60% of physician, with an agreement rate of 45%. And this means that patients are much more afraid of toxicity than older patients. So the key findings in that this is the first prospective multicenter cohort, especially assessing the expectation and priorities of patients over 70 being treated for cancer in real-life setting. The top one priority of older patients, like younger patients, is treatment efficacy. Autonomy has a high importance among older patients that remain stable over time. So we conclude there are two types of consequences. The first one is for clinical practice, in that treatment goals must be discussed clearly at the start of treatment and regularly afterward. And in clinical research, it is very important to involve older patients in the design of clinical trials in order to define objectives in line with their expectations and priorities. And that's why we created a patient committee backed by the Geriatric Dialogue French Cooperative Group. And it is also very important to include patient-reported outcome in therapeutic evaluation criteria. Thank you. And thanks to all the patients and investigators from all centers and to the study team.
Thank you very much for that great presentation. Very interesting study methods and results.
Thanks.
I will, if you want to stop sharing your screen, Camille, we can
Yes.
open it up for questions.
Yes.
I have some questions, but I'm sure others do as well. So I'll we'll leave it open for a moment. I'll stop the recording just so folks